It's not rocket science. What did the radiologists used to do with bearing members? And the patients used to come out of that totally dizzy because they've been tipped on their head, on their side, on the other way. But you've got to do that because you've got to get the air to rise and distend the colon. So always use position change when you withdraw. Always. Antispasmodics, not widely used. Buscopan, or we use peppermint oil. When I was working across the water here at Hazra, we did research studies on peppermint oil. Very powerful calcium channel blocker, not absorbed, totally safe. So no tachycardia, smells nice, and totally relaxes the colon. And this is a picture of the difference before and after peppermint oil. Very effective, and the whole place smells great. You say to the patient, if you fart on the way home in a taxi, just pretend you're having a bit of chewing gum in your mouth. And use your dye spray, or NBI or FICE or whatever else you've got. And that should be readily available. In terms of using indigo carmine, if you've got a lesion you think it's there, rather than making up a whole batch of it, but 1 ml of indigo carmine into the Barnes channel and a water chaser, so like beer and whiskey. Put the water down after it and squirt it at the lesion. We're just showing there the advantage of being able to see the tip pattern, but more importantly here, Freddie mentioned the SSA, he said SSP, we call those specialist screening practitioners. I've never sprayed one of them. Anyway, tiny little lesion here, you recognise it with a little blob of mucus. Thinking actually this bowel prep is perfect, what's that little blob of mucus doing? Yeah. Put some dye on it or turn on your narrow band and you'll find the lesion. I would agree the same thing, they're slippery little buggers, you do need to do a sort of hybrid technique to get them off. There is a sort of miss rate, and we know that. Actually, in fact, it's higher. There was a post-mortem series back in the 60s, and something like 40% of people over the age of 40 had adenomas. So we should be able to find them. And adenoma detection rate is a crude measure, but there should be around 25%. Setting your level at 20% is entirely reasonable, and you should be auditing that in your units at least 6 monthly and take action. This is a couple of years ago, maybe. So I've got a couple of people at the end here I've got a big problem with. They are not detecting adenomas. And they say, well, I don't do enough cases. Well, no, you don't do them well enough. But generally, you should be doing that for your unit. And if somebody, you all know that the guidelines on dealing with poor performers, those people need to be looked at, and similarly with the product retrieval rate. So we've got potential of basically not wiping out cancer because you won't get 100% of the people coming, but we should be able to reduce it, and we should be able to reduce it by up to 50%. But we'll never do it, whatever screening technique you use, we'll never do it unless it's actually safe, comfortable and accurate, and that's a critical thing. So go for driving lessons and actually imagine you're on a track and you're driving a colonoscope on a track. It's the same principle. That's why I drive fast cars. They're fun.
Thank you very much.